All right,
They're
great.
ready.
Thanks. Perfect. Thank you, Matt. Just one quick reminder too, just make sure to mute yourself if you're not necessarily going to be one of the presenters. You're more than welcome to ask questions during the question time, but just to kind of save, the potential audio interruptions and stuff like that, mute yourself if you can. But again, welcome to the Western New York Chemical Dependency Consortium's training on the SUD services all throughout Western New York. Just kind of give a really quick, brief, again, recap of what the training is going to be like. We're going to include some information from prevention, treatment, recovery, and harm reduction in the specific services available throughout all of our programs and stuff, just to make sure you feel better and more informed about the services that are happening all across Western New York. For structure, we're going to move in that specific order. We're going to have folks from prevention, folks from treatment, recovery, and then harm reduction present for about 10 minutes-ish each. It will be a kind of overview of the services that are available that we all do in those specific sectors or subsectors, I could say, and then there'll be a quick sort of room for talking about what it's like to work in the sector, and then maybe room for questions afterwards. As a heads up, there's going to be room for questions between each segment, if there are any. If there are questions for like maybe prevention and treatment in particular that run long, we might have to cut those off just to make sure we save room at the end for the other presenters and things like that. But if you want to wait around until after 10 o'clock, there's always going to be room afterwards for questions at that point as well. But to get things going, because it's already 9:07, so let's maybe talk about prevention coming up next. So we've got Melanie from Prevention Works, I believe, if I got that correct, and then Bridget from Western New York United. So both of you all can feel free to take it away and talk to us and enlighten us all about the fantastic things happening across prevention. Thank you.
All right, good morning, and thanks for the introduction. So I'll get us started off with basically what prevention is. So I'm going to just make sure everybody can see my screen first. Perfect. Right. So substance use prevention, there's really about 140, I believe, at one time, the number of prevention providers all across New York State. And so I'm Melanie Witkowski from Prevention Works in Chautauqua County. And so I just want to talk a little bit about what is prevention. And there's basically 4 different strategies that OASIS really recommends us follow. These are some of the strategies, really looking at reducing the prevalence of substance use and gambling across the lifespan, including, kindergarten all the way through senior citizens. Delay of initiation. We really know that the adolescent brain doesn't completely develop until about 25 years old. So really, the longer we can hold off on adolescents using substances, the less likely that they're going to be involved with an addiction concern or a substance use disorder. We really also want to look at decreasing the negative health, social, and educational and economic costs that it has on our society. And then also preventing escalation of substance use. So many individuals might be experimenting with different substances. So really the goal is to provide some intervention to prevent them, again, from needing services down the road. And so a perfect example of that program would be like a Teen Intervene brief intervention program. So if you have an adolescent or youth that's going through a treatment facility and they don't necessarily need, they don't have a diagnosis and don't necessarily need full treatment, Teen Intervene is a great option for referral. Looking really just at some of the strategies, primary prevention, and I want to just emphasize that it's primary prevention, it's not relapse prevention. Those are 2 very different things. With primary prevention, again, we're just trying to prevent early onset of use of alcohol and other substances. So it includes prevention education, classroom-based curriculum, environmental change strategies. One of the big ones that you probably have seen is Take It to the Box, where we're encouraging families to dispose of their unused medication and taking it to a drop box location or using deterra bags. And the biggest reason for that is because the majority of places that individuals find medicine is within their own home. Community capacity building, providing positive alternatives such as a after prom party where there's no alcohol or other substances. Early intervention, as well as information dissemination, which is usually held at like outreach events, community fairs, working with partners in school districts to make sure they have the accurate information. I will say that the Office of Addiction Services and Supports has approved curriculum, and these are the evidence-based prevention programs that we have. And so you can actually look at the list of programs that are available that might be of interest to some of the clients you're working with. A lot of these are family-based, where Active Parenting Now, Triple P positive parenting, strengthening families, are all about how to build family capacity and change the dysfunction that's happening in the home. And so that's a great place to look at if you feel like there's some services that could be beneficial for individuals in treatment, recovery, harm reduction. There's always opportunities for partnership. And so as a prevention provider, we are required to submit a work plan, and 60% of our work has to be evidence-based curriculum. So looking at a way that a method or a model that we use, it's called the Strategic Prevention Framework. So this is it's also called the SPIF flower. You might have seen this before. And so it really is determining assessing our client or a community that we're working with. And a community might be a school, it might be a school district, it might be a town or a city, but then building capacity with individuals that can help with your mission and what you're trying to do with the outcomes. Developing a specific plan, implementation, and evaluation with also keeping in mind, being culturally sensitive and how it can be sustainable. So prevention is extremely data driven. And we really go based on what the data says, both with what are the risk and protective factors, as well as what's happening with the individual, their family, in their community. And so we really look at reducing risk factors, like you can see on the left-hand side, and then also how can we increase those protective factors in the community. So when we're surveying our students, whether it's the community level youth development evaluation, YRBS, or Pride survey, we're trying to figure this out in each of those domains. So there's many different opportunities to partner, collaborate, and refer clients over. You can actually go to Oasis and look up the different prevention providers across the counties that are here in Western New York. And, Chautauqua County, we're the only, Prevention Works is the only Oasis prevention provider, but then you go to Erie County and there's like 4 or 5, but you can locate them, and there's always opportunities to partner, like I mentioned, collaborate and refer clients both to prevention and out to treatment, recovery, and harm reduction. So after that, I'll take that and let Bridget take it away for a day in the life of prevention.
All right. Hi, everyone. Let me just share my screen. All right. Can we all see that?
Yes.
All right. Not sure if it's letting me. Maybe. Melanie, I know you shared through Canva. Is there a certain way I can? Oh, here we go. All right. So my name is Bridget Lumko. I'm a prevention specialist with Western New York United. I'm full-time. I am within the Buffalo Public Schools. So I'm here to kind of give you a day in the life. So here's just a quick overview before we get into the programs that we offer. But in terms of a prevention specialist, like I said, I'm at my school 5 days a week, 8 to 3, and here's a little bit of what I'm doing. So like Melanie mentioned, we're in the classroom, we're teaching that evidence-based social skill curriculum. We do ours through Mendez Foundation. Through this, we're trying to teach these skills to the youth to mitigate those risk factors associated with risky behavior and to promote those protective factors associated with healthy decision making. So I also offer mentoring and support, whether that's pushing into classes, helping out kids who are having a tough time, pulling kids one-on-one, checking grades, all of that. I'm active support in school efforts to improve climate and culture, full participation in all school-based collaboratives, whether that is going to student support meetings, parent meetings, open house, multicultural night, tabling events where we're informing high schools about Narcan, doTERRA bags, all of that. We do Red Ribbon Week at our school as well. And lastly, I offer leadership and service training for selected middle school students, which we'll get more into That is our Leaders in Training 7th and 8th grade program. So kind of to get into the school programs that we offer. So like I said, I'm pushing into classes K through 6, teaching these lessons. So kindergarten through 4th grade, that is our Too Good for Violence program. It's a 10 lesson program. I'm pushing into classes for about 30 to 45 minutes. This in kindergarten through 4th grade, we're really honing in on providing the skills, knowledge, and attitudes needed for positive social development. We're working on those interpersonal skills. It's where they're developed, it's where they're used. A lot of times we get well, don't do this, don't do that. That is not our approach at all. We have interactive lessons. We have games, we have group activities, we have skits, we have social stories where they're able to practice these skills that they're learning in social settings with their peers. Like I said, it's not just a don't do this, don't do that. It's not a scare tactic. It's pushing in and really focusing on these skills to prevent them from risky behavior and all of that. 5th grade, it is a 12 lesson or 12-week classroom-based curriculum designed to improve and enhance students' ability to deal with social influences, to use substances or engage in violent behavior. So this is our own curriculum. We introduce drugs and alcohol. We give them the facts. This is kind of where we bridge all those skills that we learned, and we're putting them with, well, how are we going to apply these to real life? How are we going to use these skills to stay away from what we don't want them into, what they see every day? So we really focus on self-esteem, bringing out who they are, and things like that. That bridges us to our 6th grade lessons, which is Too Good for Drugs. This is where kids are entering middle school, that 6th grade year. We're talking about fastening our self-esteem complex, our goals. We are having more complex goals that these kids are facing. So we're addressing the environmental and developmental risk factors related to drugs, alcohol, and other drugs. We're telling them, now that they're a little bit older, we're telling them the effects that drugs, alcohol, tobacco, what they do to your brain, what they do to your body. And down low, I have what we focus on in our lessons. We work on communication, feelings, emotion management, goal setting, decision making, respect, peer pressure, relationships, all of those things that go into making healthy decisions. So past our school programs, I run a program called Leaders in Training. This is a leadership and life skill development program. 6th graders are chosen by teachers, myself, administration, and they are put into a group of called Leaders in Training. So over the course of 7th and 8th grades, that selected students participate in summer program. We do school service projects, and we meet weekly to do lessons, kind of giving them a group at school where they help get the word out about drugs, alcohol. They really help with Red Ribbon Week and all of that. I also am in charge of Ripple at my school, and what Ripple is, it's an interactive computer-based intervention program. How it works is kids that get referred to me by their teachers, we go through a checklist, what they struggle with. Maybe they have substance use problems within the family. Maybe they themselves are struggling with addiction. One of the biggest things in our schools right now that we're seeing is vaping, tobacco or nicotine, and even at the point where they are bringing pens into school with marijuana. So giving them a chance to have that one-on-one almost counseling, sitting down with them. I know Melanie mentioned Teen Intervene. It's similar, but this is for younger kids. Once again, like giving them those skills. So this is all evidence-based. So we've seen fewer out-of-school suspensions, improved grades, better attitude, problem-solving skills, and all of that. So that's just a little bit of what I do. Day in and day out, every day is different when you're working into a school, but these kids, it's right in their face, whether they're seeing things at home, whether they're seeing things in media. We're giving them those skills to prevent them from wanting to partake in drugs, alcohol, all of that. So that's a little bit of what I do. Sorry, it was kind of an overload, but. I think we're going to go into questions.
Yes. So any questions for Bridget or Melanie? And if not, there'll be room at the end too, so it's not a problem. If you have questions, you'll put them in the chat. Melanie and Bridget can always respond to them in the chat as well. I'll give it one more second.
It's not exactly a question about what was talked about, but will we get copies of the slides or anything?
Yes, I think we can do slides. Yes, we can probably make that happen. Good question. And then we'll also probably have the presentation recorded up on the Western New York CDC website. We might be able to have the slides saved there as well.
Oh, okay, that's fine. Yeah, just wondering. Thank you.
Sounds good. No problem. Thank you. So again, if you have any questions for prevention, feel free to add them to the chat or hold on to them until the end of the presentation, and we can review them at that point as well. I'm going to go into treatment next. My name is Ed Sishan. I am working for CAS Recovery in Western New York, as I'm sure most of you all work in Western New York as well. I'm not sure why I just said that, but we also have Gusam with me from Horizon Health. We're going to kind of walk through some treatment information really quickly. Let me share my screen really fast. And make this presenter-y. On the thank you slide, of course, going all the way back to the front. All right, cool. There we go. Because I ran through this right before the presentation to test it out a little bit. But again, my name is Ed Sisham. I've got Gusam from Horizon to help me out for the second half of the presentation as well. We're going to talk about treatment and what treatment looks like in Western New York. And the way that we've structured the presentation is just to kind of run through the continuum that Matt used that term already. And this is specific to the treatment continuum and how things kind of flow for individuals. And so individuals tend to find treatment through a couple different options. They might find them through referrals from other programs. They might access crisis services. They might be in a acute crisis kind of sort of situation. That service provider will refer them to a treatment provider for their specific need. They might do some online research to find out what might be the best possible program for them, depending on their area. And they might have personal or previous connections to care that they've already been to CAS, they've been to Horizon, they've been to Best Self, all those specific things. They want to come back to those specific programs. That's a common occurrence as well. One of the interesting things about finding treatment, especially through New York State, is that we have a specific assessment that must be done for each individual coming into a treatment program. And it's done typically through each individual agency's intake departments. But it's called the locator or the level of care determination. And so that form is an OASIS standardized form that providers work with the client, the patient, to screen them based on their specific information and their potential situations, their symptomology, all these specific things. And after asking them these screening questions, the locator, the tool, will let us know what is the best possible level of care and the best kind of programs for them. So we can't necessarily influence that ourselves. This individual is experiencing X, Y, and Z. They're supposed to go to this specific level of care, and that individual should be referred to that kind of program, basically is what happens. So the locator is a very effective tool for all of us to work with. And then when it comes to actually working with patients and clients in our field, treatment interventions typically involve counseling and one-on-one and group sessions. Both of those are pretty common occurrences. Through psychotherapy. And then both Melanie and Bridget reference evidence-based practices. That is a common occurrence for treatment as well. Lots of our services involve evidence-based practices or EBTs, especially cognitive behavioral therapy or CBT and dialectical behavioral therapy or DBT. Both of those are presentations that will take an hour in and of themselves. Just know that those acronyms are very important to our work. And then that is kind of how individuals find treatment. Here's what the flow tends to look like on average for some individuals coming into the treatment system. So they tend to start off with detox and inpatient. We'll talk more about each of these in a second. They then may move into a residential program if that is their need, or they might go to outpatient. That all depends on each individual's needs. You can also flow backwards. An individual might be an outpatient. They might have a pretty significant recurrent use. They might have to go back to a detox program to help manage the withdrawal, and they can move through the system wherever they need to. They might start off in detox and inpatient, move right to outpatient, depending on their needs. So all this stuff is very fluid and very person-centered for each specific person. And then below each of these specific models of care and levels of care, we have ancillary services that are contributing to the service modality and the fantastic stuff that we do in each of these programs that we'll talk more about at the end of the presentation. So detox and inpatient it's a kind of a combined-ish but distinct level of care that kind of starts things off for individuals often. So individuals in these specific programs, these programs tend to be suited for those who are in withdrawal and need medical oversight to help stabilize themselves. It can be pretty acute and pretty dangerous to be in withdrawal. And so individuals might go to detox first to help manage those physical symptoms of withdrawal, make sure that they're safe, that they're okay, that they're medically managed as much as possible. And detox really is that first stage of recovery for a lot of individuals. Again, individuals staying there for a few days, depending on the symptom that they're, or the symptom, the substances that they have in their system possibly, can vary between a couple days to longer period of time, maybe up to a week, depending on the situation. And then individuals may move then into inpatient, which that starts to introduce more of the psychological effects of SUD, not just the physical symptomology. So detox is very withdrawal focused, tends to be focused on the physical symptoms. Inpatient is a longer stay, typically around 28 days, though it can vary. And in inpatient programs, individuals start to manage both the physical and psychological effects of their substance use. And these programs, staff are on site 24/7, and they feature counselors and pretty intensive medical staff like nurses on site, NPs, medical doctors, all those specific things, just to help folks manage this very acute, very risky and dangerous stage. And then going forward, we have these in italics at the bottom, specific OASIS levels of care and regulations and things. If you ever wanted to reference those, they're available on the OASIS website, but those specifically refer to these specific detoxification programs. Individuals, they may then move to residential afterwards. So they go through detox, they've gotten their withdrawal symptoms managed. They can then move to residential, which is suitable for individuals who don't necessarily need that acute medical need for inpatient or detox anymore, but they might still need some significant support and structure to help manage their substance use. So individuals in residential may need some adult daily living skills, things like budgeting and how to cook properly, clean your house effectively, how to live more independently. They don't necessarily have those skills built up just yet. And so residential programs can help them with that. Residential programs also feature more of a group style focus. And so if you heard of rehabs, you tend to think of individuals living in a larger building together with staff on site. That is what residential tends to feature. Right now, this is complicating things a little bit. There are 3 specific levels of care, elements of care, I should say, in the OASIS system for residential. There are other ones kind of going back, there are older models too, but right now everyone's working on these 3 for the most part, which are stabilization, tends to be short-term, intensive and integrated with both substance use care and then mental health and medical care as well, all on site. It's helping folks get stabilized, tends to be again short-term. Rehab or rehabilitation tends to be more medium-term, also pretty intensive and integrated with those mental health supports and medical care, focusing on early recovery skills in particular. And then reintegration tends to be a little bit more medium-term as well, 2 to 3 months on average, depending on the person to stay in the program. They tend to be more independent and focusing on more community connections. So individuals in reintegration might be going to appointments independently. They might be going out in the community more often to help increase their independence. So these levels of care all change depending on individuals' needs and independent capabilities for residential, but similar to the inpatient programs, staff can be comprised of counselors, medical staff, and stabilization and rehabilitation in particular. Case management is also a pretty common occurrence, and then support staff and others are also available. And so those are the residential programs that are available too. I'm going to toss it over to Gusum to start talking about outpatient next. So thank you, Gusum.
Thanks, Ed. So everyone, I'm Gusum Saluzio. I work at Horizon Health Services. Just an overview of Horizon. We offer all these different levels of care internally. Some organizations do that. They offer several different levels of care in the treatment world. Some, specialize in certain levels of care, primarily doing just outpatient or primarily just doing inpatient. So it depends on what that organization offers. So I'm going to specifically talk a little bit more about outpatient because I did a great job talking about inpatient residential. So outpatient may be where a patient chooses to start their treatment journey. Like Ed said, they could come in through the detox door, they can come in through the outpatient door. Generally speaking, this is a little bit better suited for people that are a bit more independent, but still need support within their substance use. I will also say that a lot of times this might be patients that are not necessarily ready or willing to go into a higher level of care. That might also be why a patient might go to outpatient. Because you have to think people are, stopping their lives to go to inpatient and going to live and reside somewhere when they're in residential care. That is not the same for outpatient, right? They would come in for an appointment, they leave, they go back to their home or wherever they're residing, and continue to reside outside of that living area in outpatient care. So it's just a little bit different. So outpatient care can look different based on the type of treatment we're offering. Same thing happens. We offer the locator, and we do that right at the beginning of treatment with patients to figure out what level of care is recommended for that patient. Sometimes the level of care recommended doesn't actually align with what that patient is interested in. So we'll make that recommendation. We talk about it. Patient decides what they want to do. And if that patient would be best suited for an inpatient level of care, but that patient's not interested, we may offer them intensive outpatient, which could include several groups a week. It could include peer linkage, also medical treatment, and then in addition to that, individual counseling on top of that as well, to get that patient into the office as many times as humanly possible in a given week, just so we're seeing that patient with regularity and trying to work on stabilization at an outpatient level instead of inpatient. So outpatient level of care can also include opioid treatment programs. Also just outpatient could be as, less frequent as, once a month, once every few weeks. It really depends on what the need is for that patient. This is the largest sector of the treatment world. So staff may see patients in various ways, like we talked about. They do individual and group therapy. A lot of the day-to-day in the outpatient world is back-to-back services. We're trying to get as many people seen as humanly possible. The need and demand in our community is high. So, the schedules are pretty packed. So patients are coming in for their individual sessions and then also being seen for group. A lot of this is done in person and also via telehealth. Some patients are seen for shorter term, like episodes of care. We might also recommend a patient go, to a higher level of care so that patient may transition out of outpatient and then come back to outpatient after they've done detox and stabilization. And then sometimes, based on medical necessity, they may be linked with us for a longer period of time as well. You can go to the next slide. So in addition to counseling services, there are other services that are attached to a lot of these programmings. Again, depending on the organization, some organizations offer more ancillary services than others. At Horizon specifically, we offer addiction medicine. So we have MDs, PAs, and NPs that all see our patients for medication-assisted treatment, consultations, MOUD, which is medications for opioid use disorder, depending on what that patient's interested in or looking for. And a lot of times it's just a consultation discussion about here are your options in terms of what we can do in utilizing medication to support your recovery and your services that you're getting with your counseling. Some patients are not interested in that, but it's good to offer that option to them. We also have nursing services. Nurses can offer medical, consultations. They can also be the ones that provide injections for injectable medications that a patient may be on, because medication-assisted treatment can be offered via injection or oral medications. In addition to that, we do have psychiatrists on staff too to offer support for mental health needs that might be going on. Care management or case management is also a really good option to see what that patient might need in the community. Sometimes there's housing needs, there's vocational needs, there's just community-based needs, linkage with primary care doctors, all sorts of things that case management might be supporting that patient with. And then in addition to that, peer services is kind of wrapped into that treatment outpatient world as well. So internally at our organization, we offer that at Jump for any patient coming into services. Are you interested in peer-like support? Would you like to get linked so they can actually have a peer and have their counselor and possibly a case manager and a medical provider? So it's this treatment team kind of approach in the outpatient world. Next slide. So the goal will be, looking to maintain recovery for that patient. And I know we're going to talk about, harm reduction in a little bit. So it might look like different things in the outpatient world. For one person, recovery can look like, complete abstinence. For another person, recovery could look like I have reduced my, use of something risky, and maybe I'm still using something else that wasn't really a goal of mine. So for example, a patient might say, I really want to cut down and stop using opiates and get on medication-assisted treatment, but I'm not willing to stop using marijuana. For them, it might be, best course of treatment for them to work on getting on buprenorphine. They're managing their opiate use disorder, and then, they may continue to use marijuana. Somebody else may say, I want to be abstinent from all substances. I don't want medication-assisted treatment. I want to actually do self-help meetings. So maintaining recovery in the outpatient treatment world can look really different just based on whatever model that patient would like to participate in and whatever recommendations we're making. So it's a collaborative approach between the treatment provider and that patient. Next slide. Just staffing and education, what this looks like. So we have our counselors, which we talked about, our medical staff, peers. So credentialing and background and licensure all kind of looks different depending on the types of positions that are in, the realm, depending on the organization. So at Horizon, we have MDs, NPs, PAs, and then our counseling staff include KSACs, LMHCs, LMSWs, LCSWs. And then we also have like entry level clinical staff as well, which could be MHCPs or people that are still in their schooling program, just kind of finishing out. We also have interns participating in the program as well, that can help support our patients in different ways. We also have peers on staff, so that might be SERPAs on the substance use side of the world, and then on the mental health side of the world, we have mental health peers as well. So it's kind of a mix of different backgrounds that help to support that patient on their treatment journey. This also includes really intensive clinical supervision. We want to make sure that these patients are getting everything that they need. So supervisors will take a look at the case, make recommendations as to what they think that patient might benefit from. And of course, we come back to that patient collaboratively and we discuss recommendations from the treatment team. Hey, we recommend based on what's going on with you that we do intensive outpatient, or, we recommend detox, or we recommend you continue doing one session, bi-weekly because you're stabilizing and you're doing really well. It kind of just depends on that patient, what they're looking for and what our recommendations are. So we treatment plan with our patients collaboratively and we come up with the best course of treatment for them. Next slide. That might be the last one. All right. I know we might save some questions for the end, but any initial questions about treatment, outpatient, inpatient?
I think we're good. And if anybody has questions, just in the interest of time, add them to the chat for now. We can kind of answer those throughout the next parts of the presentation. I'm going to toss it over to Nathan from Best Self, who is a senior peer leader. If he wants to share his screen, get his presentation started, that would be fantastic. So Nathan, it is up to you now.
Awesome. Okay, how's everyone doing today? Like Ed said, I work at the Recovery Community Center at 69 Linwood in downtown Buffalo. I'm just here to talk about recovery a little bit today. So the first thing I know about the Recovery Center is that all the staff that work there, from the program director to the peers who work there, are all certified recovery peer advocates. So no matter who you go out in the door, you're going to have somebody there who's a certified recovery peer advocate. We welcome people in all stages of recovery, like Golson was saying, so people who are just considering changes up to people who want full abstinence or anywhere in between. We recognize and respect the multiple pathways to recovery. The coolest thing about us is that we don't do any fees, no co-pays, no referrals or insurance necessary. So that means that say somebody is linked with Horizon, Evergreen, or somewhere different, it doesn't matter. They can still come into the recovery center and receive services. They don't have to worry about getting billed. They don't have to worry about insurance. Anyone over 18 that is thinking about changing their life or identifies as being in recovery is allowed to come in. And that's just kind of basic about it. So we do a lot of different recovery activities, and that's what it looks like most of the time. So just to kind of run through some of them, and this isn't a complete list because I would have had to make a lot more slides, but just cover a few of them. So some of the mutual support groups we do are things like coping skills, gratitude, mindfulness, TED Talks, and during the summertime when it's warm enough out, we do walk and talks. Some of the self-help groups we do are definitely the ones people know about. So we do Alcoholics Anonymous 3 times a week on Tuesday, Thursday, and Saturday. We do Narcotics Anonymous every Friday. We do Smart Recovery and SOS on the weekends. And we're looking to actually add dates for those hopefully soon. We also do different life skill groups such as baking. We have a group that we do once a month called Chef It Up. That is a really long 3-hour group where we bring a group into a kitchen. We teach them basic chef skills and things like that. And recently we actually added something from personal medicine. We have a peer coming in from a different location every week who does a personal medicine group that just help people prioritize like what they need in their life. So it's a way to really kind of like sit down and find like a unique personalized way for you to get your recovery going. We do some harm reduction groups such as harm reduction, Narcan training, and recently we've been partnering with Roswell to get a smoking cessation group from them started, which has been awesome. And then we also do family support groups such as Amazing Creations, which is like different arts and crafts and things like that. We do a movie night once a week, and we encourage people to bring their families in and do that kind of stuff. And we also do understanding addiction for the family. So if anyone has family members or friends that doesn't really understand the world of recovery or anything like that, they can bring them in and just learn a little bit about this field and what it looks like. I'm sure everyone can relate to that and how confusing this can be to try to explain to people outside this field. And then lastly, we do have volunteer opportunities. So we have something called the Western New York Peer Workforce Development Center, which is an opportunity for people to get their SERPA. That's actually the thing that I went to get my SERPA certified. So I love that program. I think it's awesome. And it's all free training. We will pay for your exam. All the trainings are paid for by the program. It's something like 50 hours in total of 4 different trainings. I think I have them covered right now by my screen, but it's medicated supported recovery. It is this Connecticut Community of Recovery CCAR training, and then a ethics training as well. And then after that, you would get your temporary certification. You have 2 years to get 500 hours volunteering, which is why we offer the opportunity to volunteer at the center. And after you have those 500 hours in 2 years and take the test, you can get your full certification and you get fully certified as a certified recovery peer advocate. And we rely on our volunteers a lot in the center, actually. So as far as the day-to-day stuff goes, the day starts out typically in the morning. We almost start every single day with a mindfulness group. So that would look like volunteers sitting at the front desk, greeting people as they came in while a different peer got ready for the group. After mindfulness, we hop into kind of the flow of the day, just running different groups throughout the day. And on top of that, the main thing we do is that we're kind of a resource broker. I tell people all the time that I don't ever know what my day is going to look like. We have a lot of people coming in off the street, coming in out of hospitals, coming in out of rehab. So a lot of people who are just kind of looking to get back on their feet and don't know where to start. So the main part of our job that we do is we do a lot of referrals out to like housing programs. We do a lot of referrals to like different programs for like primary care, whether that be mental health or medical health. And we also do just a lot of just helping people figure out what they need. So that's the big thing we tell people when they come in is that we're never going to tell you what to do, whatever it is you need when you're coming up with the street, whether you need help with housing, whether you need help getting connected with different services, we're going to point you in the right direction. And that is what I have for everyone today. Sorry if I spoke really quickly, and if anyone has any questions, please let me know.
That was great, Nate. Thanks. Really good overview of all the recovery resources that you all have to offer. That has worked out well in terms of timing that we've got left. Now we've got harm reduction up next. And so if you have any questions for Nate, again, add those to the chat. We can always kind of come back to them at the end of the presentation if there's time as well. But I'm going to toss it over to Sam and Zachary from Evergreen for you all to go next.
Hello, everyone. I'm Sam. I am a behavioral health project manager over at Evergreen. So I help some of the projects that are going on there, and we're going to talk a little bit about harm reduction today. So at Evergreen, harm reduction has been a part of our mission and core values for the past 40 years or so. So whether a person's using drugs, is looking to use more safely, reduce their use, or stop, our team is there to meet them where they're at, really. So we have harm reduction services in downtown Buffalo, Jamestown, and also by way of our mobile unit so that can get out to some harder to reach areas. Really, the team's aim is to provide tools and services that help people who use drugs work towards their goals, on their own terms and in a dignified and understanding environment, what that may look like for them. So what does that look like? First and foremost, syringe exchange is one of the most fundamental examples of harm reduction, and it's really at the core of what we do. In Buffalo, we provide syringe exchange to about 100 people a day. In Jamestown, about 50. And then, like I said, our mobile unit goes out to some harder to reach areas. So on Mondays, we go out to the west side, on Tuesdays out to Dunkirk, on Wednesdays out to the east side, and then on Thursdays, Niagara Falls, and every other Friday out to Lockport. Anyone who injects drugs is eligible for anonymous enrollment, whether it be substances like drugs, or vitamins, or hormones, or whatever the case may be. Any kind of injectable substance, we can help you out. And like I said, it's anonymous enrollment, and all exchange services are free regardless of your insurance status. So that's really great that we can offer that. One of the important components of the syringe exchange for the past, 30 or so years that it's been around in New York State is Hep C and HIV testing. Syringe exchanges have been proven effective at reducing the transmission of bloodborne illness, particularly Hep C and HIV. So in programs like ours, you're going to see a lot of messaging about how to prevent the transmission of disease, about testing opportunities that we have, and how the diseases are treatable. Yeah. So for some of our other services, I'm going to pass it along to Zachary to pick me up from here.
Good morning. My name is Zachary. I'm a referral coordinator for the low threshold buprenorphine program. And with that, I work pretty closely with the drop-in services we provide at our downtown location. It's in our walk-in building adjacent to the clinic. It's been around for 2 years now, and it offers a very cozy setting for people who may be intimidated by a clinical setting or maybe earlier in the recovery. You'll have access to showers, laundry, group activities, ice cream socials, lockers to keep their things if they're facing housing instability. And it just gives them kind of a safe space, supportive space, just to stop in through the day. And it gives us a nice place to kind of like have a warm handoff, more like formal services at Evergreen's clinic next door. One of those services that is offered next door is our low threshold buprenorphine program. It's been serving around 100 patients since 2018 between our Jamestown and Buffalo locations. We have 3 providers that offer appointments throughout the week, and they offer telehealth too to kind of meet patients where they're at and make sure that appointment adherence is as easy as possible. All these patients will receive Suboxone, Zubsolv, or Sublocade. We're proud to announce that we just released or started rolling out Sublocade for our Jamestown location. It's an awesome program. I'm really proud to work with it. Becoming more and more popular to work in conjunction with SEPs. It's definitely the more clinical thing we do as a harm reduction program. And it fits well with Evergreen's larger Oasis outpatient MAT counseling for patients who are like, which is a bit more ready for stability. We'll kind of graduate them onto that program. Right next door to our low threshold bupe program, we now offer wound care as a walk-in service from a family nurse practitioner who's also a psych NP. So she can provide walk-in wound care. She can bridge scripts if patients are having a little bit of trouble attending their appointments. Really important since we've just started detecting more xylazine in the area and noticing more wounds, abscesses, and skin infections. These patients can be walked down by primary care providers or nurses to the clinic that's just adjacent. Hopefully, only going to get more and more popular. I hope everyone can refer their patients. We do kind of have the bandwidth to help people with transportation. So if you ever need, you can give us a call and transfer. We call the harm reduction. Well, someone will be able to help them get here. We do this with the funds that we're fortunate to have from the New York Department of Health, who's the primary funder of harm reduction services. These are offered Tuesday, Wednesday, and Thursday morning at Evergreen. More service that we offer, supportive conversations, supportive counseling, conversations about manage and safer use, and then linkage to other services. 2 types of dialogues consistently happening in all these spaces. For linkages and referrals for detox, inpatient, outpatient, and housing. But there's also a lot more informal conversation. And that's really just making sure patients know that we're here for them, that we're going to be an ear to listen, and that it's going to be as easy as possible for them to come back and work with us for whatever that may look like for them. It's really about building rapport and treating people with dignity.
Yeah, and then last but not least, we have our Drug User Health Coalition meeting. That's every Thursday we hold that. So this is a feedback and advocacy coalition that's comprised of people who use drugs or used to use drugs. It's really awesome to have some individuals who can help inform our model of care and discuss new services, other needs that they might have that aren't getting met. But also, helping with advocacy issues in the community, you know, thanks to the support of our peer outreach navigator. A key part of harm reduction is not only offering, you know, the practical and quality services that Zachary was talking about, but also, you know, really changing the way our world views people who use drugs and talking about the war on drugs and specific legislation we can advocate for, and, you know, keeping in mind these are people we're working with. You know, recently some of the specific legislation they were talking about had to do with the drug checking bill that, you know, did make it to the floor, but unfortunately didn't get passed through. You know, seeing people get involved in talking about issues that matter to them is, you know, a huge deal. So with that, what does this look like day to day? Zachary, what does it look like day to day?
So some days a bit busier than others, but usually pretty smooth. Within the SCP, we got a couple worker bees working on different things. So we'll get them started. We always have coffee going for patients in the morning. The front desk at the SCP, they'll get their supplies. They may get some Narcan training. They'll have access to a monitored restroom, as well as computer charging stations. There they can get signed up for Hep C testing or HIV testing. They can get linkage to inpatient and kind of have like a spot for that to do that off the side. The mobile unit will get ready for the day. And go to their respective units. We'll send out those mass texts to patients signed up for that about any contaminated batches or any areas we'll go to. Patients can also reply to that to get a drop off to their home or a more specific area if they're not able to go to the site that they're going out to for the day. We'll also lead syringe sweeps or cleanups in the neighborhood. We like to leave that open for staff at Evergreen to join them too, just to get a little bit more manpower, but it also gets our Evergreen staff more familiar with our harm reduction team. The drop-in, again, we love getting coffee going, getting ready for the day, snacks, food ready for patients who may be stopping in. We'll get patients starting to sign up, get their laundry in, get some, we have some art therapy, get a documentary going, try and just make it cozy. We'll have staff there that are able to refer them to primary care, refer them over to the low threshold use program, complete a matters referral with them if they're not really kind of ready for sticking around yet, but they're thinking about MAT. And then within our low threshold use program, when patients are already enrolled in the day-to-day, like just making sure that they're ready to see the provider, making sure their insurance is checked, providing reminder calls, texts, keeping a constant line of communication ready. We'll meet the supportive counselor, the LPN, the provider, the referral coordinator will meet quickly and just kind of talk about what patients will really focus on for the day, make safety plans, and just kind of make sure patients are feeling comfortable while they're in the clinic, especially if it's kind of a few clinical settings that they're experiencing right now.
Thanks. I'll also add, you know, our folks out in Jamestown paired up with New York Matters and have a couple of Narcan vending machines out there that are available for people to use. So that's also making sure that's stocked up is a part of it. So who are the people that do all this great work? What's great is we have people from a whole bunch of different backgrounds. You know, many different kinds of people find their way to harm reduction centers to work here. You know, like other programs, you know, we're going to have social workers and mental health counselors, you know, people with lived experience, certified peers, but more importantly than anything else, you know, we want people who love the people we work with, that love people who use drugs and want to support them and help them along their journey, whatever that may look like. So I think that's us. Thanks for listening. Any questions for us? You know, we're getting towards the end here.
Perfect timing, though. We have time for questions if anybody has them. Again, thank you both for a great presentation on harm reduction. So there's time, a couple minutes at the end here. If anybody has any specific questions, you can ask them and unmute yourself. You can use the chat if you'd like. And if not, if the presenters want to send their slides to me, and then I can send it to Kate to post on the website, and then Matt and I kind of coordinate around the recording of the presentation. We'll have this available probably within the next few days, maybe, depending how quick this goes, for everyone to view later. And then the eventual plan is just to kind of be able to use this as an ongoing resource for staff members all across the field, the sector, all those kind of sort of things. So if anybody wants to refer this to other staff members, somebody new who might be starting, you might think they would use some good high-level overviews of prevention, treatment, recovery, and harm reduction services, you can use this as a resource going forwards. So any questions, again, one last time?
There's one point that came up in the chat early on in the presentation. I'd just like to quickly answer the question if I could. The question came up about wanting prevention services in specific counties. And the way it kind of works, folks, is that every county in the 8-county region, I think in every county of the state, there is a prevention organization that is in charge of the prevention activities that are happening. We heard from Melanie from Prevention Work. She's in Chautauqua County and provides the work in Chautauqua County. Bridget works for Western New York United Against Drug and Alcohol Abuse, one of 7 different organizations that provide services in Erie County. If, for example, someone wanted services in Niagara County, the North Point Council would be the first call to make because they're the ones primarily in charge of providing services in Niagara County. Now, that doesn't mean that arrangements couldn't be made if there is a lack, but the first call is to that specific organization in each county, just to clear that up. What a great amount of work, right? I mean, this is an incredible, wonderful experience in terms of all the different kinds of work that we do, such a variety of jobs, such a variety of daily life experiences. I hope it brought forth a greater understanding of what each other does. I hope it's useful in the future for new people who join the field or for anybody who cares at all about SUD to understand the variety of services that we get to provide here in New York State. And we hope that this becomes a useful tool for people as we go. Ed, thank you so much for the corralling of this talent and the making sense of this 1 hour. We know we only scratched the surface. We know that there's a lot more variety even than what we presented here. We just wanted to start the dialogue because we are definitely stronger if we all work together, and there are opportunities across the different disciplines to serve the people that we are here to serve even better. Ed, anything else?
I think I see Timothy has a question. Also, thank you, Kate, for answering those questions in the chat that I see popping up too. So great job, Kate, for working through the chat. And Timothy, do you have a question?
Just really quick, what is the distinct difference between MOUD and MAT therapy?
So MOUD is specific to opiate use disorder, but MAT really implies medication-assisted treatment, which is more of like the umbrella term that talks about any sort of medication that might be used to support substance use recovery. So that could also include like Camprol or Vivitrol, which some of those work specifically for alcohol cravings. So there's different types of medication that can be used for different types of substance use cravings and whatever it is that you're coming in for. So that's more of the umbrella term versus MOUD, which is specific to opiate use disorder specifically. So that's more of your buprenorphine. It might be Vivitrol, could be Sublocade, Brixadi, some of those medications that are specific to opiate use disorder. Did that help answer that question?
Yeah, so yeah, the MOUD is then specifically just for opioids, and then the MAT therapy is for alcohol and opioids.
Yes.
Perfect answer, Gustav. Thank you for taking that one. Good job. Any other questions while we're here? Again, great job with the chat and stuff. Love the feedback and the information that we got. Glad it seems to be helpful so far. And if you ever want to access this later or send this to other folks, we'll send out the recording at some point in the next few days. So again, thank you all so much. Again, thank you so much to the presenters. You all did a fantastic job. Thank you for your time and effort with this presentation. And thank you to the attendees for being here. We appreciate your attention over the last hour. And right on time, 10 o'clock. So great job, everybody. Thank you all so much. Talk to you later.
Thank you.
Thanks again,